Interesting topic. It's an acute kidney injury and acute renal failure by senior alumni Shankar Niranjan. He is from 88 batch, 88, and he was the president for KMC in 91 and 92, and the senior under officer of NCC in 90 and 91. Then he went to UK and he stayed in UK for 2 years and he got an MRCP. Then he moved to US residency and he went to the University Connecticut. He did an internal medicine and he did nephrology and he is continuing as a clinical faculty. And he got a prestigious award, Thomas Preston Award, in the year of, and he is a chair of National Kidney Foundation. And he is now doing a National Kidney Foundation in Western Massachusetts and Connecticut. And he is very interesting. He does lots of cycling and traveling. So more than that, he is a representative for all our US alumni. And any of you needs anything to move to US or any you need any help, and he is the best person. And not only about helping our students, he is heavily involved with the rural projects of kidney projects in Tamil Nadu and the Tamil Nadu Foundation. So we're going to listen to him, and he's a great chap with not only as a clinician, and he's a very socially motivated thing. And please feel free to contact him for any help through the messages. If you have anything you need for us, I will leave it to Dr. Shankar Niranjan for next 1 hour. At the end, we will have a doubt session. Please start.
Prasad, thank you for your kind words. It is a pleasure for me to come back and teach the medical students in KMC. Long dream come true. I teach medical students, both UGs and PGs here regularly. So it's nice to come back to our own alma mater and teach the next generation. Thank you all for making time on Saturday evening. As you know, I'm a nephrologist by profession, and it is one of the rewarding things for me to teach the next generation of people about acute kidney injury. So I have to thank Prasad and all of the organizers, first of all, for offering a platform for me to talk to you about acute kidney injury, because this is a good thing in the time of COVID-19 infection, when we're all homebound for the most part, that we at least have the technology that we can continue to learn from each other. So thank you, Prasad. So why did I choose this topic, acute kidney injury and acute renal failure? So I don't know how it is right now in KMC, but at least when I went to medical college between 1988 and 94, basically what you learned in medicine was rheumatic heart disease and mitral stenosis. In surgery, you learned about hernia and hydrocele, and in OBGYN, you learned about prolapse. Those were the important things that you learned. And I personally did not have any experience with acute kidney injury until I became a CRRI. And if you had asked me 30 years ago if I was thinking about being a nephrologist, I would say no idea, because at that time I did not even know what a nephrologist did. So, and I will tell you why the acute kidney injury and acute renal failure is very fascinating. If you look at all the organs in the body, the organ that gets the most blood supply per gram of tissue is the kidney, okay? Not even the brain, not even the heart. So 25% of the cardiac output in any given minute goes to the heart. So, sorry, to the kidney. So if you think about it, and I joke with my cardiology colleagues all the time, that the heart may be the most important organ in their opinion, but even the heart, the function of the heart is to pump blood to the kidneys. So I think the kidney is the one that maintains your milieu interior, as you all know. And the study of the kidneys is something that takes you to remind yourself of the wonderful physiology that you learned as a first year and second year, as the pharmacology and pathology that you learned in your clinical years. and put it all together in your medicine. So, and I will tell you why, because, and the reason I told you what every clinician should know, because anybody, no matter what specialty you're going to go into after medical school, you will encounter someone with acute kidney failure, okay? And just a simple Google search about common causes of death in India. So I'm not going to talk to you about exotic diseases in the Western world, though I have trained in the UK and US. Let us just look at what causes things, common causes of morbidity and mortality in India. Say if you're going into pediatrics, acute diarrheal illness, acute gastroenteritis, commonest cause causes dehydration and acute renal failure. If you're going to be an obstetrician, think about postpartum hemorrhage. If you're going to be just a gynecologist, blood losses around the time of hysterectomy and all of that, that causes acute renal failure. If you just are going to work in the casualty department, or you're going to be a surgeon or an orthopedic surgeon, think about one of the commonest causes of death amongst adults in India, road traffic accidents, which causes internal hemorrhage, rhabdomyolysis, causing acute renal failure. So you don't have to be just a physician to know about acute renal failure. No matter what specialty you're going to go into, you have to have some idea about what acute renal failure is. So when I was a medical student, when I was even doing my PG, there was no good definition for acute renal failure. Everybody knew what acute renal failure was. If the kidney stopped functioning, we called it acute renal failure. But now in the 21st century, we have much better definition. So, initially it started off with some studies that was done in the 90s. They came up with something called the rifle criteria. So they assessed the risk, injury, failure, loss, and progression to end-stage renal disease, or ESRD. So, for example, let me say, you have somebody who has had some bleeding episodes or, hematemesis. So they are at risk because they lost blood. And when actually their creatinine starts going up in the blood, then you call it injury. Then eventually, when they start needing other measures to support them, like dialysis, you call it acute kidney failure. And if the kidney is not coming back for a while, you call it loss, and eventually you called it ESRD. So this is the criteria they used in the 90s to see or define acute renal failure. And then they came out with the term acute kidney injury as opposed to acute renal failure, because renal, for many people, didn't know what it meant. It's a Latin word. And failure also meant that somebody failed something miserably. So injury is a more appropriate term. So there was a group called the Acute Kidney Injury Network. So they came to stage kidney disease. And this was incorporated into what's called the KDIGO guideline. So if you do a search of, it stands for kidney dialysis, international global outcomes. That's what KDIGO stands for. So right now, the way we define acute renal failure or acute kidney injury is if you have your serum creatinine, this is assuming you know what the patient's serum creatinine is at baseline. Say they came into the hospital, you saw them in the OP, you ordered some blood work at baseline, their creatinine level was 0.8. Okay, let us assume that is normal. Okay, so they have been in the hospital for 3 days. They have been treated for pneumonia or whatever you're treating them for, or GI bleeding. And 2 days later, you see their creatinine is up to 1.3. Okay, so that is more than 1.5 times what they came in with, because they came in at 0.8. So that will be at least a class 1 KDIGO AKI. Okay, so you can call it mild AKI, moderate AKI, severe AKI, but it is something that if you want to be more objective about it, you can call it class 1. And the other criteria is urine output. So if their urine output is less than 0.5 mils per kilo. So if their body weight is 70 kilos and they're making less than 35 ml of urine in an hour for 6 hours, then you call it class 1. And same with class 2, where the serum creatinine has doubled. So if they came in with 0.8 creatinine and after a few days it is up to 1.7, 1.8, it is a more severe form of acute kidney injury. And here also the urine output criteria is taken into account. So we call it a severe AKI or class 3 KDIGO class, or a class 3 AKI if their serum creatinine is 3 times more than the baseline. So they came in at 0.8, or their creatinine 2 weeks ago when they went to see their doctor, they brought all the reports with them, their creatinine was 0.8. Now they've come to the casualty or they've been admitted to the CCU, and now their creatinine is 2.5 or 3, then the kidney function has worsened 3 times compared to the baseline. So that is called severe acute kidney injury. Or any increase over 4 milligrams per deciliter. So if they came in with a creatinine of 1 2 weeks ago and now they are 5.5, that will be class 3. Or initiation of renal replacement therapy, which is dialysis. Okay. So, and again, the urine output criteria is also taken into account. That is less than 0.3 mils per kilo per hour. So if they are say 70 kilos and they are making less than 20 ml per hour for more than 24 hours. So that will be less than 500 ml per day. That is really the definition of oligonuria, right? So less than 500 ml per day. So that is where we are. So the next issue we look into is anytime you talk about acute renal failure, we always categorize it. We categorize this as pre-renal, renal, and post-renal. It is a very important classification that everybody should be aware of, and I will tell you why. So, if we are going to use, and I use this analogy with the medical students all the time. If you are, using the analogy of the example of a car, okay, the car has an engine. Let us assume the kidney is the engine. The kidney is really not an engine, but the kidney is a sophisticated filter. We all know that, correct? So let us assume the kidney is an engine. It needs some petrol from the petrol tank of the car, right? So the engine may not be getting enough petrol, or the engine may not be working well because it is not getting enough petrol, or there is some problem with the engine itself, which is the renal cause. And finally, if the exhaust pipe is blocked and the combustion byproducts are not able to get out of the engine, that is going to clog up the engine and it is going to make the engine malfunction. Okay, so that is how you have to think about pre-renal, renal, and post-renal causes. So, and we are going to look into what these things are on a day-to-day basis. Okay, so first of all, the post-renal cause of acute renal failure or acute kidney injury is the easiest to rule out. Assuming you can get a kidney ultrasound scan or CAT scan or even good physical examination skills, you're able to feel a huge bladder, then the patient is obstructed. If you can get a ultrasound either at the bedside, and again, I'm not talking just at the medical school or medical college level. Let's say you go into practice and you're in a private institution, you can get an ultrasound in the next 1 or 2 hours. You put a Foley catheter and they put out 3 liters of urine, then they had some kind of obstructive uropathy. So what are the common things that cause obstructive uropathy? So if you think about it, you can divide them as lower urinary tract and upper urinary tract. So anything bladder and below is called lower urinary tract. So you can have urethral stricture, or you can have prostate problems, commonly BPH or prostate cancer. You can have neurogenic bladder. Neurogenic bladder can happen for various reasons. Diabetes, spina bifida, paraplegia, all these things can cause lower urinary tract bladder dysfunction. So all these things, when there is a problem, then you are not able to get the urine out. The urine can get backed up all the way into the kidneys. It can cause hydronephrosis and it can cause an elevation in the serum creatinine. So that is the one of the important causes of acute kidney injury. Upper urinary tract, we divide them into intrinsic and extrinsic causes. So intrinsic causes is anything that is intrinsic to the lumen of the ureter or the kidney. So it could be a stone or a big blood clot, or it could be a tumor. So you can always ask me, sir, do you have 2 kidneys? How is it that if you have a stone in one kidney, you can get acute kidney failure? The answer is you cannot. If you have, say, one functioning kidney, because somebody has either donated a kidney or because they had childhood urinary infections and they already lost one kidney, it has become atrophic, and you have only one functioning kidney on the other side, if that kidney gets blocked, then you can get acute kidney failure, right? So nature gave us all enough kidney function. So, you can live with one kidney healthy, but if that kidney is blocked, then it's a problem. So if you have a stone, or if you have a, blood clot, or if you have a tumor, or if you have some lymphoma infiltrating the ureters, all that can cause blockage. And extrinsic causes, things like retroperitoneal fibrosis, which we see rarely, things like huge AAA, abdominal aortic aneurysm, which can cause blockage. All those things can cause it. So the long and short of it is, the reason I'm telling you is this is the easiest amongst the causes of acute renal failure to rule out, provided you have the technology. Okay. So if you have an ultrasound or a CAT scan that you can get straight away, or if you can put a Foley catheter and you can demonstrate the patient put out 2 liters of urine, then you've already addressed the cause of the acute renal failure. So just to go back and remind ourselves, this is like thinking about the exhaust of the car being blocked. So you've cleared the blockage. So now the engine is able to function better. So the next one is what we call pre-renal versus renal. So the engine or the filter may not be working well because you're not getting enough blood flowing into the engine at all, or enough petrol flowing into the engine. So this is not an easy problem to distinguish, but there is ways in which we can distinguish this. And I'm going to talk to you, extensively about what are the things that cause pre-renal and what are the things that cause renal, acute kidney injury. So what we do, if you have the facility, we check the spot urine sample for sodium, and then we calculate what is called the fractional excretion of sodium. This is what is done commonly. Very rarely, we also check fractional excretion of urea. We won't go into all of that because we don't have the time for it. But a very common thing we can do, or what we call a poor man's testing of all these things, is you give them like a half a liter or 1 liter of fluid, and if they start making more urine and the next day their creatinine comes down, they were pre-renal. So you still had time to address things. And urine microscopy is key. So as a nephrologist, this is something I do on every single patient of mine with acute kidney injury or acute renal failure. So if I'm called to see the patient, I look at the urine, and I'm going to show you some pictures. They have coarse granular or muddy brown casts. We call it acute tubular necrosis, or ATN. If we see a lot of white cells or WBC casts, we call it acute interstitial nephritis. And if we see a lot of RBC casts, it is called acute glomerulonephritis. Okay. So these are things that we see on urine microscopy. And these are all renal causes of acute kidney injury. So now we're going to talk a little bit more about what are the things that can cause pre-renal acute kidney injury. So if you think about it, if you want to look at it systematically and you want to rule out things, you want to look at it this way. So there is true volume depletion, apparent volume depletion, altered intra-renal hemodynamics, and abdominal compartment syndrome. And I'm going to talk to you about each of them in a little bit of detail. So before we go into that, let us think about it this way. So we will go back to our analogy of the car engine and the petrol tank. True volume depletion is when you either forgot to put in petrol for your car, okay? So there is no petrol at all in the petrol tank, or there is some kind of a leak. Something happened to the petrol tank and it is starting to leak gasoline or petrol, so there is not enough coming into the engine. Apparent volume depletion is where you actually have enough. Okay, so the volume status in the body is normal because you have enough fluid, but it is all in the wrong compartments and it is not reaching the kidney. So again, with the car analogy, the petrol tank is full, but the pipe that connects the petrol tank to the engine of the car, there is a problem. There is either a blockage, there is a kink, or there is something that has happened to it. Okay, and the third one is altered intra-renal hemodynamics. That is like the blood flows into the kidney, but there is something wrong within the kidney itself. Okay, so there is the microvasculature of the kidney that is affected, and that is also a very common problem. I'll tell you what it is. Abdominal compartment syndrome is a rare condition, but you will see it if you look for it. So I will talk about that also. So what constitutes true volume depletion? So how can you lose volume from the body? Just remind yourself, I'm not telling you this is true dehydration. Dehydration is not a word that nephrologists use because you're not losing water alone. Okay, you're using extracellular fluid. So we call it true volume depletion. So hemorrhage. So hemorrhage, any bleeding of any sort. So you could be a victim of a road traffic accident. You have lost a lot of blood. You could have GI bleeding. You could be bleeding from a peptic ulcer, or a diverticular disease, or hemorrhoids, or anything for that matter. You could have menstrual losses, significant menstrual losses because you have profuse DUB. All these things constitute hemorrhage. And you could also have bleeding diathesis. So you could have, you may not get hurt in a trauma situation, but you could be having some bleeding diathesis and lose blood. So GI losses, when I ask medical students, how do we lose volume in terms of the GI tract? Everybody is keen to answer this with two things: nausea, vomiting, and diarrhea, or vomiting and diarrhea, right? So if you're throwing up what you're eating, or if you're having extensive stool losses, those two things cause GI losses. But in the real world, you also have to think about a few other things, okay? So one of the things is fistula. So if you see a surgical patient who has developed complications, they could have fistulas, right? So they could have fluid leaking into the skin because of something going on in their abdominal cavity. They could also have things like ileostomy and colostomy and things that we create artificially. So that also is part of GI losses. And surgeons put drains. So there are biliary drains, there is other drains, JP drains we put after surgery, and you could be losing volume from there. So don't underestimate the volume losses from these drains. So you can really lose a lot of volume. And one of the common tubes and drains things I tell students is the NG tube. So you have somebody coming in with suspected gastric outlet obstruction, you put an NG tube, and as soon as you put an NG tube, they put out 1.5 liters of either coffee ground material or biliary material. So you have made note of it. But if you connect it to low wall suction over the next 24 hours, if they lose 2 liters of fluid there, you have to take it into account. If not, you're going to miss the whole picture. So all these things cause GI losses. So what I'm trying to tell you is, don't just stop with diarrhea and vomiting. Look for other causes. You may have patients with ostomy or drain in the surgical setting, or they may have NG tube losses. Okay. So GU losses, when you lose fluid through your genitourinary tract. So again, commonly I have, when I ask medical students, they all come up with exotic things like salt losing nephropathies and other things like that. All that is good. But what is the commonest scenario where you lose a lot of fluid through your kidneys? It is what we do to patients, right? We give them diuretics. So that is a very, very common cause. So don't forget it. A lot of the patients for hypertension or for congestive heart failure or for any reason, they're taking Lasix or Bumex or anything like that. And on top of that, if you have uncontrolled diabetic, don't forget the fact that these patients can have osmotic diuresis. So I'm sure you all remember from reading your physiology, there is something called tubular transport maximum. So anytime your blood glucose is over 180, you start spilling glucose in your urine on an average. And if your glucose is 300 or 400 or 500, yes, you are going to lose a lot of fluid in your urinary tract. And sometimes we use things like mannitol, which can also cause osmotic diuresis. So don't forget other causes for GU losses. So this is all the ways you can lose fluid from your body. So the top three, these three are very important. The other two, not so much. Pulmonary losses used to be a big thing before they have humidified ventilator circuits. Now we have humidified air in most of the ventilator circuits, so you don't lose a lot of fluid there. Patients with cystic fibrosis, again, not very common in India, we don't see that, but if they do, then they lose fluid there. Skin losses, don't forget that. Excessive sweating, if you have some kind of erythrodermic condition, extensive skin rash, exfoliative dermatitis, all those things, you can lose fluid. And finally, burns. Burns, I'm sure you all go to the burns ward and Roy Pata Hospital or KMC, it's a very sobering place. But if you think about what you do for these patients, first thing you do a cut down or hook up an IV and start them on IV fluids, because they all lose so much. The skin is the largest organ in the body, correct? So if the skin is burnt, you lose a lot of fluid from the skin. So the next topic we're going to talk about is apparent volume depletion. So these are conditions where the total fluid in the body is normal or even on the high side. So think of somebody with congestive heart failure. So what happens? The heart is not doing its job as a pump. So it is not pumping enough blood flow to the kidneys. So the kidneys are thinking that the patient is dehydrated because they're thinking, oh, enough blood is not coming. Maybe this guy is losing blood somewhere. Maybe this guy is vomiting. I have to hold on to salt and water. So all the mechanisms that are involved in this get revved up. So things like aldosterone, all the mechanisms, the normal homeostatic mechanisms kick in. and it make you gain salt and water. But what happens to the salt and water? It doesn't come into the actual intravascular compartment, and what it ends up doing is staying in different compartments. It stays as edema, it stays as water in the lungs. So it is apparent volume depletion. So you've not really lost any volume, but your body thinks you have lost volume, which is not a good situation. So these conditions, all these conditions, these 5 conditions, we commonly talk about them as a decreased EABV. EABV means effective arterial blood volume. So as you know, the kidneys, the juxtaglomerular apparatus, you know all these things. You read it in physiology, macula densa. These things sense how your blood pressure is, how the intravascular volume is, and that is the way they are actually, responding to things from the external stimulus. So when the kidneys sense that you don't have enough volume coming in, so you could be having CHF, or if you're cirrhotic, all the fluid is going into your peritoneal cavity, ascites, nephrotic syndrome, where everything is edema and not coming into the intravascular space. Anesthesia, it could be in the wrong compartment. If you're septic, based on the location of where you're septic from, the fluid could be going there. So all these conditions are apparent volume depletion. So again, when you think about acute kidney failure, you see somebody with a, you're called, if you're the CRRI or you're the PG, you're called to evaluate somebody with a creatinine of 3. Your mind should automatically go through all of this. Is this person volume depleted, what we commonly call dehydration, or are they apparently volume depleted? So both these things you have to keep in your mind. The other thing is altered intra-renal hemodynamics. So the first 2 topics, hepatorenal syndrome and hypercalcemia, we will talk in a bit. But the most important scenario that you are going to come across is the last one I put there: ACE inhibitor use, ARB use, and non-steroidal anti-inflammatory use. Okay, so at least over the last 25 years, we are using more and more ACE inhibitors and ARBs, medications like lisinopril and losartan and valsartan and all those things. We use for hypertension, we use it for congestive heart failure, we use it for a lot of conditions. And we also use non-steroidal anti-inflammatory medications. So it doesn't matter which part of the world you're in. If you're in the Western world, if you have back pain or if you feel like you have the flu, you take some ibuprofen. In India, you go to a medical shop, you ask the pharmacist instead of going to the doctor, he prescribes you some ibuprofen, or he just gives you some ibuprofen or naproxen, something like that, you take it. So these are good medicines for, NSAIDs are very good medicines for pain relief, provided you are otherwise healthy. Say if you are 25 years old, you are an athlete, you eat well, you drink well, you have no problems, NSAIDs are fine. But think about how NSAIDs work. Okay, NSAIDs, the mechanism of action is by inhibiting prostaglandin synthesis. So let us come back to the kidneys and look at this for a second. So let us assume a situation where your body is stressed, either because you are truly volume depleted, because you are vomiting or you're having diarrhea, or you're not eating well because you have the flu or pneumonia. So there is not enough blood going into the kidneys. So what is the first response of the human body? The response of the human body, I told you, is to make sure the kidneys get enough blood flow. So the mechanisms that you all read in your physiology get revved up. And one of the key players in this is angiotensin 2. And what does angiotensin 2 do? Angiotensin 2 causes significant afferent arteriolar constriction. So it makes sure the pressure to the kidneys is good, and it makes sure that whatever blood is flowing, it goes with a good pressure into the filters of the kidney. So if you have a condition where you have extra angiotensin 2, it can cause significant afferent arterial vasoconstriction to such a point that it can deprive the kidney of any blood flow. You don't want that situation. The kidney doesn't like that situation. It wants the blood to keep flowing. So what does the kidney do? The kidney secretes local prostaglandins around the juxtamedullary apparatus and all of those things. So the prostaglandins are secreted. They actually mitigate the effect of the angiotensin 2. So the prostaglandins make sure the kidneys still get some blood flow into the kidneys. So if you are taking somebody who's volume depleted or who's in congestive heart failure or who has GI bleeding or anything, and you give them a couple of non-steroidal anti-inflammatory drugs, you are going to knock off that prostaglandin synthesis. So what happens is unopposed angiotensin acts on the afferent arteriole, which means the kidneys are not going to get blood flow, which means they're going to get an ischemic damage. So that is very important. The ACE inhibitors and ARBs, as you know, act on the other side. They act on the efferent arteriole. Okay, so the way they cause, if their effects is by causing some efferent arteriolar vasodilatation, right? So that is how they work in proteinuria. So if you have somebody with diabetic kidney disease and they have a lot of proteinuria, they cause some dilatation of the efferent arteriole, and thereby you basically drop the pressure at the intraglomerular level. So you're going to be causing less proteinuria. But if you give it to somebody who has low blood pressure, you're going to drop the filtration pressure further and cause acute kidney injury. Another commonly used thing is iodinated contrast. So we use it for coronary angiogram, we use it for CAT scans all over the world. And iodinated contrast media, basically what it does is, it also causes a very significant vasospasm in the kidney arteries, and thereby it causes prolonged ischemic injury. Two other things, hypercalcemia and hepatorenal syndrome, they also work this way. Hepatorenal syndrome affects the small arterioles and capillaries of the kidneys. At the big level, the kidney isn't actually damaged. Anatomically, it is not damaged. So when a patient with hepatorenal syndrome dies, you take that kidney and you put it into somebody else with a normal liver, it will work fine. Okay, so it's all humorally mediated. So that is why this category is important to remember. So we will come to the questions at the end, because we have to make sure we will finish in time. So I'm going to go through all the causes and what we can do about it first. So just jot down your questions mentally or in a piece of paper, and then we can talk about it. So renal causes of acute kidney failure. So the commonest renal cause of acute kidney injury or acute kidney failure is ATN, or acute tubular necrosis. So ATN, we typically talk about it as ischemic ATN or toxic ATN. So ischemic is where your kidneys are deprived of blood flow. So all the things we spoke about in pre-renal cause, okay, all the things, the diarrhea, hemorrhage, everything, if it continues on for a long period of time, then basically your kidneys are going to be deprived of blood supply. This is how people die of acute kidney failure. Say, they don't get enough medical care, even after snake bite and all those things. We're talking many causes of ATN. But if you're volume depleted and you don't put enough blood supply into your kidney for a long time, then basically you're going to have your kidneys result in ischemic damage. So it is a spectrum. So you start as pre-renal failure, but eventually it is going to end up in ischemic ATN. So typically your patient will have blood pressure, they will have blood loss, all those things, and it will cause ischemic ATN. So the other cause is toxic ATN. So what causes toxic ATN? When we think about toxins that affect the tubules, we typically think about medications like gentamicin. We think about a lot of other medicines, amphotericin B, all those things cause it. But the most important thing you don't want to forget is pigment. Okay, so damage from muscle pigment causes rhabdomyolysis, or a lot of hemoglobin from hemoglobinuria or hemolysis, massive hemolysis. All those things can cause toxic ATN. Acute interstitial nephritis, we'll look into it further. This is the commonest cause of acute kidney injury in hospitalized patients in the Western world. Non-hospitalized patients in the Western world. So ATN is in the hospitalized patients. AIN, or acute interstitial nephritis, is in the non-hospitalized patient. Very common things that will cause this are infections and medications. There are a whole lot of medications, including antibiotics, all kinds of things that can cause AIN, and a whole lot of infections that can cause it. Anything from bacterial, rickettsial, parasitic infections can all cause acute interstitial nephritis. Amongst the medication, the commonest one worldwide is proton pump inhibitors. So you don't want to forget that. So if somebody is taking omeprazole or pantoprazole or any of those prazoles, they can cause acute interstitial nephritis. Worldwide, because of the fact that it is available widely and everybody is using it, it is the commonest cause of acute interstitial nephritis. The third cause is acute glomerulonephritis. So we're not talking about people with just frank nephrotic syndrome, but we're talking about people with what we call rapidly progressive glomerulonephritis. Okay, and if you remember your Robbins textbook of pathology, you probably read about them as crescentic glomerulonephritis. So anything that causes full-blown inflammation of the glomeruli will cause acute kidney failure. So things like that, very common things, are post-streptococcal GN. Okay, so after a strep infection, you can have glomerulonephritis. After endocarditis, you can get it. If you want to think about more, interesting causes, you can think about connective tissue diseases. So lupus can cause a severe lupus or class 4 lupus can cause acute glomerulonephritis resulting in acute kidney injury. As a nephrologist, I see even more complicated cases, things like ANCA-positive vasculitis. You only read about them in textbooks, but these patients really exist. So what we used to think of as Wegener's granulomatosis, they've changed the term now. They don't use the term. They call it, microscopic polyangiitis and all those things. So those things can all cause acute glomerulonephritis. It is very important to know these conditions, because if you treat these conditions aggressively right after you make the diagnosis, and if the patient's glomerulus is still in a good shape, then you can prevent these patients from going on dialysis. I'm sure most of you know that when patients go on dialysis, it is a pretty hard life. And especially if they are young people, it is very difficult. And a lot of them end up needing a kidney transplant and all that. So you want to avoid that. You want to know what is going on. And as we saw in one of the earlier slides, the hallmark of acute glomerulonephritis or a nephritic picture is patients will tell you they have dark urine or cola-colored urine or tea-colored urine or smoky urine, whatever you want to describe it. They will have some edema, they will have some hypertension. That is typical presentation. If they also have other things like hemoptysis, you want to think about renal pulmonary syndromes and other exotic things, okay? Last but not the least, acute vascular syndromes. So this is something that is commonly overlooked as a cause of acute kidney injury, but it has to be in the differential diagnosis. So very commonly, the things we see as nephrologists are malignant hypertension. Somebody has had hypertension for 5 years, they have not taken any medication. They are coming to the emergency room, or they have been admitted for something else, or they've had a stroke and their blood pressure is 260 over 140 and their creatinine is going up. They probably have severe malignant hypertension. Other things very commonly we see atypical hemolytic uremic syndrome and what we call TTP, thrombotic thrombocytopenic purpura. These things are they come under the broad category of thrombotic microangiopathies. And you don't see much in India, but in the West you can see scleroderma, which is also something that causes acute vascular syndrome. So the distinguishing point for the vascular syndrome is it doesn't cause red cells or red cell cast, or it doesn't cause white cells or white cell cast or anything. The urine, if you look at the urine, it's usually bland. And that is how you think about other things. You put everything in the context of the clinical picture, and then you come up with a diagnosis. If you have TTP, you will also have other things. There is the pentad of TTP, where you have fever, thrombocytopenia, microangiopathic hemolytic anemia, neurological problems, and renal failure. So that is how you kind of arrive at it. But not all those 5 things have to happen in the same patient at the same time, okay? So this is from a patient I saw last week in the hospital. This is acute tubular necrosis. As you can see, these things are the muddy brown pigmented granular cast. Okay, so you see 1, 2, 3, few more here, few here. So this is not even a high power field. It's I think the intermediate power field. I can see about 15 or 20 casts in this. So this is muddy brown cast of ATN. And this is one of my other patients with lupus. As you can see, what you are seeing here, this is the regular urine analysis. What you see here is red blood cells in the urine. You know they are red blood cells because they are smaller and they are, if you look at a high power, you'll be able to say they are biconcave disc shaped. This is somewhat of a lower power. And then they don't have nucleus or they don't have any granular matter in them. That is how you know it is a red cell. And this is my other patient with acute interstitial nephritis. So here you can see this is not red cells, this is all white cells. You can see it's white cell because inside the white cell you see granularity, you see nucleus. So it has the granular. So all this is polymorphonuclear leukocytes. You cannot tell that for sure. Sometimes it's also eosinophils, but usually this is what white cells in the urine look like. This is pyuria, okay? And this is a patient I had with lupus, where you can see red cells that are biconcave disc shape, okay? They look like a donut or vadai, whatever you can call it. And then you have some white cells also, and you have a cast that is a cellular cast, okay? So the patient has a cellular cast, and you can also see some white cells in the field. So not everything is red cell, you can also see some white cells. And this is a field, I put a little bit of stain on this sample. This is a patient with urinalysis that shows a lot of white blood cells. You can say you can see this faintly stained, granular matter in the white cells. So just a word about acute interstitial nephritis. So initially, when they described it back in the 1970s and 80s, it was thought to be secondary to infection. And then in the 80s and 90s, they saw more of this in patients with drugs. Typically acute interstitial nephritis, if you read the textbook description, these patients have fever, they have eosinophilia, they have a rash, usually a maculopapular rash, all those things. But you don't have to have all those things. You can just have elevation in serum creatinine in the right setting from appropriate drug use with white cells and white cell cast that will clinch the diagnosis for you. And lately, over the last few years, we are seeing more acute interstitial nephritis from autoimmune processes also. So things like lupus can do it. Other things can also do it. So lupus, for example, can cause anything in the kidney. It can cause vascular damage, it can cause glomerular damage, it can cause tubular interstitial damage, anything, okay? So I gave you the definition for acute kidney injury right at the beginning. The 1.5 times, 2 times, and 2.5, 3 times, all those things. But the problem is if you have somebody who is morbidly obese, obesity is a problem all over the world now. Even in India, we are seeing, if you see somebody 120, 130 kilos, the creatinine is a waste product we base on muscle mass. So these patients may be 130 kilos, but not all of it is muscle. There's a lot of fat tissue, so it may not be accurate in these patients. And so people with liver disease have low muscle mass, so you cannot rely on the creatinine alone. Patient in the immediate post-operative period or after admission to ICU, where they get a lot of fluids, the creatinine gets diluted, so it may not be very accurate. So who actually is at risk for acute renal failure? So when I teach medical students, I tell them anybody who has higher body mass index. I'm sure most of you know how to calculate body mass index. It is very easy. You need to know the height and the weight of the patient. So if you have somebody with a body mass index of more than 30, the odds ratio of developing acute kidney injury is more than 2, in spite of you controlling for all other factors. Anybody who has intra-abdominal sepsis, so subdiaphragmatic abscess, liver abscess, anything else, and if you have delayed initiation of antibiotic for any sepsis, that can cause acute kidney failure. Anybody with pre-existing chronic kidney disease. So if you already have a creatinine of 2, then you are at higher risk for acute kidney injury. Those who are taking ACE inhibitors and ARBs, doesn't mean you cannot give this patient, but you have to think of these people are having higher risk. Anybody who needs blood product transfusion, not because of the transfusion, because if they need transfusion, they've had hemorrhage, they've lost some blood and all those things. And even people who have proteinuria for any other cause. So I'm going to skip this slide for the sake of time. And I just want to let you know, if you have multiple acute kidney injuries in the hospital or even otherwise, then your proportion or your chance of survival goes down over a period of time, okay? So the top line is where you have no acute kidney in the hospital, no acute kidney injury at all, then your chance of surviving for the next 8 years is about 90%. The proportion surviving is 0.9, that means it's about 90%. Whereas if you've had more than 3 episodes of acute kidney injury, your chance of surviving comes down to like 45%. So you want to try and avoid acute kidney injury if you can. So how do you treat acute kidney injury or acute renal failure? If you have a offending agent directly, you know a particular medication is causing it, or bleeding is causing it, or some infection is causing it, you try and remove the offending agent. You treat the hyperkalemia and volume overload. So if the patient is making urine, you can give them Lasix and you can prevent volume overload. But if they are having low blood pressure, don't give a diuretic. It will make it worse. If they have hyperkalemia, you can put them on low potassium diet. If that doesn't work, you can give them some potassium binding resins. You can do all of those things. A key thing that I do as a nephrologist is make sure all the medications are appropriately dosed. So what happens sometimes is I have patients who are coming in. They are coming in with confusion, altered mental status. They are not able to give any history. Then the admitting team calls me because the patient has a creatinine of 4 or 3, and they say patient has uremic encephalopathy. You have to dialyze the patient. Then when I look through the patient's medication list, they're taking gabapentin, 300 milligrams or 600 milligrams 4-5 times a day. This is a very high dose. It is for patients with normal kidney function. So if they come in with acute kidney failure and they're still taking the same dose of gabapentin, what happens? The gabapentin metabolites accumulate in the setting of acute renal failure, and they can cause confusion. So in those situations, if we can do the dialysis and we can remove the metabolites of gabapentin, the next morning you see the patient, they'll be a totally different person. They will be able to wake up and give you a good history and talk to you. And you want to avoid further nephrotoxic insults. So if somebody already has high creatinine, you don't want to give them NSAID medication or gentamicin or contrast if you can help it. If they are pre-renal, you want to treat them with hydration. If they are obstructed, you want to relieve the obstruction. If they have AIN, you treat them with steroids. And last but not the least, we always have what we call extracorporeal therapies or dialysis. I'm going to tell you a word about it. But the bottom line, the basic fact remains that if you have patient who is in the emergency room or in the ICU that you are called to see for acute kidney injury, you have to first of all look at the patient. Okay, so clinical examination and history taking, like any other medical specialty, is paramount. You want to know what medications they're taking, what they're looking like. If they have dry mucous membranes, poor skin turgor, they have no edema, their lungs are clear, they're tachycardic, it probably means they're intravascularly depleted and they need IV fluids. Okay, if they are having abdominal pain and you can actually palpate a bladder, you put a Foley catheter and relieve their obstruction, you will take care of it. If they are also coming in and they have JVP up to the angle of mandible and they have edema, 2+3+ edema, they're having crackles in their lungs, all those things, then you know this patient has CHF and you want to diuresis them properly. So again, looking at the patient, there is no substitute for it. Clinical exam and history taking is still paramount. So very simple few slides about dialysis. I'm sure all of you read in your high school, chemistry in 12th standard, diffusion, convection, all these concepts are familiar to you. If you come to medical school, this should be familiar to you. So dialysis, basically the process of diffusion is used where things move from a higher concentration gradient to a lower concentration gradient through a semi-permeable membrane. And when you apply pressure to this one side, you also move water. Okay, that is the ultrafiltration. So in dialysis, we do both of those things. So if you think about it, in a dialyzer, if you have blood going in one direction, dialysis fluid going in another direction, and if it is looking like this, the concentration, let's say urea is 100 here, 75 here, 50 here, because it's going down to the lower concentration. What happens at the end of this circuit is this also becomes 50 and this also becomes 50. Then it becomes inefficient. You're not having any change happening yet. So technically in dialysis, what we do is the blood goes in one direction, the dialysate goes in the other direction. So you always have a good concentration gradient. So that way the process keeps going on. So we apply pressure on one side and remove water also. So if you are allowed to go into the dialysis unit, either in KMC hospital or Rayapeta or even in a private setting, if you go and talk to the dialysis nurses, they will teach you a lot about dialysis. And that is how I learned about dialysis, other than reading from books. So the blood flows in one direction and comes out in the other direction. The dialysate, as I told you, comes in one direction and goes out the opposite direction. And if you actually cut the dialyzer and look at the cross section of the dialyzer, this is what it looks like. They are small tubes, capillary tubes inside that contain the red cells. That's all they contain, and a little bit of plasma. And outside is where the dialysis is flowing. And it's a semi-permeable membrane, so you get transfer of waste products. And this is what the dialysis machine looks like. So this is what the dialyzer is, and this is what it looks like in a standard setting. And for patients who are very sick, if the option is available, it may not be available in KMC, I don't know, But if you go to a private setting, a tertiary care hospital, they have what is called continuous renal replacement therapy, where you can do dialysis in people who are also hypotensive. Normally, you cannot do dialysis in patients who are hypotensive. So this is what that situation looks like. And this is what the machine looks like. A little more complicated. This is from my ICU. So you have ventilator and you have this CVVH machine all right next to each other in the same patient. So I don't think I have much time to go through a lot more things because we are coming close to the 1 hour mark and I want to leave some time for questions. So I'm going to skip through some of these slides. So if you're going into cardiology, you have to remember cardiorenal syndromes, very common cause of acute kidney injury. So the type 1 is somewhere who has acute MI or acute decompensated heart failure that causes acute kidney injury. Type 2 is where you have chronic heart failure and that causes increase in creatinine levels. Acute renal cardiac syndrome is somebody, let's say they have acute glomerulonephritis and they get volume overloaded, that is causing congestive heart failure. And type 4 is chronic renal cardiac, and type 5 is secondary. So it is secondary to diabetes or lupus or sepsis or anything like that. So hepatorenal syndrome is another condition you see commonly in patients with cirrhosis. It is a diagnosis of exclusion. So all this information, I can pass on the slides to Prasad and you can basically take it. So you don't need to take notes, but all this information is there. It is a diagnosis of exclusion. As long as there is no other cause for renal failure in a patient with acute or chronic liver disease, then you call it hepatorenal syndrome. And we have good treatments for it these days. So I will skip the slide on pathophysiology for the sake of time. And this is the differentials. Like I said, you look into all these things and make sure they're not bleeding, they're not on a lot of diuretics, and they don't have other causes. So this is basically how it happens. And this is again, initially the patient does not have ascites, they have mild cirrhosis, they have normal kidney function, then they have ascites which is responsive to diuretics, where their kidney function slowly starts going down, and then they come to an avid sodium retention or avid salt retentive state, where you give diuretics, their ascites doesn't get better, then you start tapping them, and eventually they go into hepatorenal syndrome where they have functional renal failure. As I told you earlier, the kidney anatomy is still preserved, but functionally it is not working. So the things that can make it worse are things like intercurrent illness and drugs and all of that. So cancer patients, if any of you are going into oncology, are going to take care of cancer patients, are also at very high risk for acute kidney injury. So you have to keep that in mind for a lot of reasons. They don't eat well, they are dehydrated, they have high calcium level. There's this n number of reasons you can talk about that. And one of the common cancers that causes kidney failure is multiple myeloma. Don't think this is a disease only in the Western world. Two of my very close friends, actually one of my KMC classmates' father developed multiple myeloma 10 years ago and passed away from it. Another friend's father in Bangalore also had it. So it is widely prevalent in India also. So you have to think about multiple myeloma in the appropriate age group and setting. So if you have an older patient complaining of back pain and having new onset of kidney failure, they're anemic, they have high calcium, all those things, you should you should think about myeloma kidney. And I'm not going to go into the treatment for reasons of time right now. One other reason I wanted to tell you for cancer patients is tumor lysis syndrome. Suppose you start them on chemotherapy, or they have a highly proliferating tumor like a lymphoma or leukemia with extensive metastatic disease. They can have spontaneous tumor lysis. Or if you give them chemotherapy, then the cancer cells can lyse, and all that lysed cancer cells and tissue is the byproducts of that is coming into the bloodstream. So it can cause high potassium, high phosphorus, high uric acid. The high uric acid can clog up the kidneys and cause tumor lysis syndrome with acute renal failure. These days, good oncologists can prevent it. They use medications to prevent the uric acid formation. And at least I don't know about India. I'm sure anything that's available here in the United States is now available in India. We use a recombinant urate oxidase enzyme. It's called rasburicase that converts the urate to the allantoin, so that becomes more soluble. So the urate does not clog up the kidneys. So you can manage the acute kidney injury. So just a picture where what happened is this patient had very high uric acid level, almost 20 milligrams per deciliter in the setting of cancer. And they get the 6 milligram rasburicase here. And as you can see, the uric acid level went down, and along with it, the serum creatinine also went down significantly. From a level of 5 it was when they got the medicine to a level of less than 1. So it's a very good, successful strategy there. So take-home messages from my talk. So, if you have a patient who's fluid overloaded, to some extent, it masks the detection of acute kidney injury. And patients with acute kidney injury or acute renal failure need to be monitored closely, even after hospital discharge. Just because their kidney function gets better in the hospital, you cannot say everything is fine and go home and forget about them. You should bring them back in 2-3 weeks, check their blood work again, make sure they have not slipped back into that. Hepatorenal syndrome, we can treat better now. Myeloma kidney, we can screen better now, and we can treat tumor lysis syndrome effectively. So that is basically what I have to say right now. And I just want to thank you all for listening, and I will be available for taking questions.
It was an excellent presentation by Dr. Shankar Niranjan, and even I think it's a very basic thing, but it was presented in such a way, I think everybody is going to be interested in nephrology. So it's really impressive. And I think there are some questions from, I think Vijay Bhaskar Varadarajalu. Maybe I will read that question. Could you kindly enlighten us about spot sodium and how to interpret the values?
So, sorry. Thank you, Vijay Bhaskar. Thanks for that question. So spot sodium alone is not going to tell you anything. So what you have to do is you have to get a spot sodium level and a spot creatinine level. So you calculate the fractional excretion of sodium. Okay. So when you calculate the fractional excretion of sodium, if your kidney tubules are still functioning, then it is still capable of getting the sodium back from the tubules into the bloodstream. That means the amount of sodium that is going to be in the urine is going to be very less, correct? But you cannot just base it on the sodium, because if you eat a bag of potato chips and you check it, your urine sodium will be high. Whereas if you don't eat anything and you check your urine sodium, it will be low. So you have to interpret it in the context of the creatinine level in the urine. So that is why you check a spot urine sodium and a spot urine creatinine, and then you calculate what's called the fractional excretion of sodium. And if you if you go on the Google these days, you can actually calculate the fractional excretion of sodium very easily. And if the fractional excretion of sodium is less than 1%, okay, that means you are in a pre-renal state, which means you can still hope for resuscitating the patient and getting them better. If the fractional excretion of sodium is greater than 1, that usually means it is it's a non-pre-renal cause, which means the tubules are not able to avidly collect the sodium back, and then it is going to be dumped into the urine. So this comes with some caveats. So if you give Lasix to somebody, you are going to drive the spot urine sodium higher, correct? So in that case, you cannot rely on the fractional excretion of sodium. So that is where we use what is called fractional excretion of urea. So because urea is not affected by the Lasix dose, we can substitute the urea in the urine quantity for the sodium, and we can calculate the fractional excretion of urea. So now I have, I'm seeing a follow-up question from Raj. It says, how to know whether patient has pre-renal failure or has he gone in for ischemic nephropathy, and tell us about volume restriction or replenishment in both. So if you don't have all the tools, and if you think the patient is dry, like I told you earlier, if the patient is hypotensive, tachycardic, they look dry, they say, if it walks like a duck, if it talks like a duck, and it quacks like a duck, it's probably a duck. So if the patient is dry from all those, from the clinical standpoint, then you are better off just giving them a fluid challenge. Give them 1 or 1.5 liters of fluid and see if they're starting to make urine, if their blood pressure is coming up, if their heart rate is coming down. All those things are your clinical parameters to judge. Now, if you're given the patient, say 3 liters of fluids, and their blood pressure is better, their heart rate is better, but they're still not making urine, you have a Foley catheter, you've excluded other causes, then they're probably gone into ATN. So if they've gone into ATN and they have still a very good blood pressure at this point, you're not going to drop their blood pressure by giving them intravenous diuretics. I think it is okay to try a trial of diuretics to try and make them a non-oliguric acute kidney injury. The fact, if you make them non-oliguric acute renal failure, then you're trying to avoid volume overload, because that is one of the indications for dialysis. And also, if they start making urine, they will be able to get rid of potassium. So that is also one other way you can prevent dialysis. So if I'm getting to see 100 patients with acute renal failure in my hospital in a given week, I will probably only be dialyzing 8 or 10 of them. The other 90 people I will be managing conservatively, either with fluids or Lasix. So I think what is more important is when not to dialyze a patient, as opposed to knowing when to dialyze a patient. Their indications for dialysis are very easy. We know we can dialyze if the patient is not making any urine, their potassium is very high, it does not respond to medical therapy and all those things. So the answer to that question, if the patient is pre-renal or have they gone into ischemic ATN, is if you've tried all the maneuvers, if you have given them enough fluid, blood, whatever you have to give them, their blood pressure is up, and they are still not making urine, they're probably gone into ATN. Any other questions?
Any other questions? Yeah, in other words, thank you, Dr. Niranjan. I think it was an excellent presentation, and I think the students are really, I think, if they attended this session, they can do the nephrology very well. I think they have in a few months' time they have an exam, and if you have anybody has any doubts or anything, I think you can contact Dr. Niranjan maybe by your email or.
Yes, email will be fine. I think I'm getting a question from Purnima about contrast-induced nephropathy. Do you have a question, Purnima?
Yes, Niranjan, I was just wondering if you could just say a few words about that, and it's a common scenario here. I do not know how common it is in India, or whether they are taking any precautions for that, and do they look out for it? Thank you.
Okay, very good question. So, the more procedures we are doing, the more contrast-induced nephropathy we are seeing. So what happens, as I told you earlier, is once you use iodinated contrast, physiologically what the iodinated contrast does is it causes a blush. Okay, so patients who get contrast for a CAT scan will tell you when the dye is pushed through their vein, they feel a blush in the skin and feel a blush in the face. It causes some vasodilatation. So the same vasodilatation also happens in the microvasculature of the kidney. But we have the mechanism of tubulo-glomerular feedback. What it thinks is suddenly it thinks there is a surge of blood flowing into the kidney for some unclear reason. And if the blood is going to flow like this, then the patient is going to keep making a lot of urine and get dehydrated. So the kidney tries to clamp down on it. It's a profound vasoconstriction in response to the vasodilatation that happens with contrast. Okay, so in most people it doesn't do anything because the vasoconstriction is temporary and then it gets better after a little while. But in patients who have impaired autoregulation of their renal microcirculation, so if you're diabetic, if you're old, if you're dehydrated for some reason, or if you have pre-existing kidney disease, all those things, your renal autoregulation process is impaired. So at that point, you have the intense vasoconstriction, but you are not able to vasodilate soon thereafter. So the vasoconstriction is sustained and prolonged for a few days. And afterwards, things get better. But in that process, if you're not making any urine at all, your potassium levels can go up. If you're not making any urine, you can get filled up with fluid. And if you already have a cardiac condition, remember, a lot of patients are getting the iodinated contrast because they're going for a cardiac catheterization or something like that. They're compromised. Then what happens is they're not able to breathe and they go into flash pulmonary edema. In those situations, dialysis is needed to take care of the contrast nephropathy. For the most part, patients will not feel anything. We just notice it in the blood work, and things get better in 3 to 5 days' time in about 90-95%. So what can we do to prevent contrast-induced nephropathy? So what I tell people is, first of all, don't give the contrast unless absolutely necessary. I educate my patients with pre-existing kidney disease. Let's say you go to the emergency room and they say, we don't know what is going on. We're going to get a CAT scan and find out. If you don't have severe symptoms and they cannot find out, and you have pre-existing kidney disease, it's probably not a good idea to get a CT scan with contrast. If it is a life-threatening issue, if you're suspected of having aortic dissection, or if you're thinking a very high pre-test probability of getting a pulmonary embolism, then yes, in that situation, you have to go ahead and get the contrast and bite the bullet and get this done. So first of all, don't do the test unless absolutely necessary. Second, if you absolutely need it and you have some time, make sure the patient is not super dry. So at least give them 500 cc's to 1 liter of fluid. It can be normal saline, it can be Ringer's lactate, anything, so that the kidneys are not feeling totally dry in that situation. There are other agents that have been used over a period of time, but nothing is consistently proven to be beneficial, because in the last 20 years I've been practicing nephrology. We have, every few years something comes up. We can use N-acetylcysteine, we can use bicarb solution, we can use this, we can use that, endothelin receptor antagonist, but nothing has so far played out and proven useful. So we've stopped using anything other than tell the people who are doing the procedure, hydrate the patient ahead of time a little bit. And that's the way you can prevent it. And you monitor the kidney function closely for the next 24, 48 hours, because it can happen anytime within the first 48 hours. Okay. So Prasad, thanks again for the opportunity. And if the students have any questions, they can reach me, they can email me on this topic. I'll be happy to answer. And if at some point you want me to talk about chronic kidney disease, because that's a very different topic, I can do that also. I can do a basic lecture.
They're all interested to learn. I think there are, so usually we are getting the participants around 30 to 40 for the sessions. So we are not really insisting on them to attend. So whoever is really, I think these bunch of pioneers, and they're really going to get good things from all of you. And please, you can have one more session. I think when the next cycle comes, please teach them chronic kidney disease.
Thank you.
Yeah, I think we can close the session. Thank you. We'll meet in the next 15 days time with the next new topic. Thank you, Dr. Niranjan, and thank you all the participants.
Thanks, Prasad, and thanks everybody for listening.